Good day everyone, I am Victor, the moderator for this webinar. I welcome everyone for today's webinar, which is CMS Medication Administration and Management for Medication, Blood Administration and Safe Opioid Use. I want to introduce our presenter for today, Laura A. Dixon. Laura A. Dixon, BSJDRN CPHRM, was COPIC Director of Facility, Patient Safety and Risk Management and Operations from 2014 to 2020. Laura holds a Bachelor of Science degree from Regis University, RECEP of Denver, a Doctor of Jurisprudence degree from Drake University College of Law. I would now like to hand over the floor to the speaker. Over to you, Laura.
Okay, and thank you very much. We are talking medications and opioid use today. We're going to have a brief discussion on preventing opioid overdoses. All right, quickly, deficiency reports. It includes every type of hospital, whether you're an acute, a critical access hospital. So let's go ahead and start with the conditions of participation. And for medications, it's in pretty much three areas. You'll have it nursing. That's the primary area. And also we're covering medication administration and safe opioid use. Now, pharmacy has some involvement in this, but the primary area in the manual is nursing. Now, pharmacy does have some that impact nursing. So overall, CMS will call them drugs and biologicals. Joint Commission goes a little more simple, and they call them medication. So starting, these are in the nursing section of Appendix A. They must be prepared and administered according to state and federal law. Preparation and administration, we follow national standards of practice along with federal and state laws. CMS does allow others to document and sign the order. Drugs have to be administered according to an order or standing orders. The medical staff, or if you have a medical executive committee, must approve policy and procedures on medication administration. For example, of course, during orientation and annual training, maybe you want to do continuing ed. Policies, procedures address what is required in your training. On the 5 rights, we're all familiar with them. We've learned them throughout our training, but your policies must reflect the accepted standards of practice, and that is those 5 rights. The right dose, again, what was prescribed. It's not too high, and yet it's effective. But there's another process, and that's the overall medication process. Now, surprisingly, right after they talked about administration, CMS puts in the guidelines of culture of safety. They also talk safe injection practices. ISMP, Institute of Safe Medication Practices, has put out guidelines and also organized factors. So here's just some of the guidelines. Have them in a ready-to-administer form, so there's no guesswork. Putting more than one medication in a single syringe. And then finally, on compounding, they do have guidelines. They revised them in 2016. Other key guidelines, if you're going to use an outside source for compounding, try to minimize that. CDC has also been involved in this because, of course, the possibility of transmission of infection. Beyond use date. This is when the drug becomes outdated and no longer usable. Timing. They did change the timing of when we had to administer medications. So there are 3 time frames. Time critical, 1 hour before and after, and 2 hours before or after. Well, let's start about those who are not eligible. You cannot set up a time for these folks, these type of drugs. And then there's pretty much everybody else. Those where you can have an established time frame. Your eligible medications must be listed as per policy. Time criticals, that's where before, after 30 minutes can have an impact on that therapeutic effect. Then we're those that are not so critical on time. If it's shorter, if it's longer, it's not going to really impact that patient, the therapeutic effect. And again, you've got 2 hours before, after, or 1 hour. Now, as far as your policy include, what does the nurse do if it's outside that window or if they miss a dose? Another thing you want to do is periodically evaluate your policy. Look at it. One other thing we need to do is assess our patients, of course. Of course, we know that staff are expected to include what is the patient telling you about that medication's effect on monitoring for our high alert medications. That would usually include our regular assessment of vital signs. Here in the medical record section, tag 4 A0467, it does specify the required content, and that includes all orders, notes of treatment, medication records, and anything that's necessary to monitor that patient. What is the surveyor going to do? Well, they're going to verify, first off, your policy and procedures are approved on the ordering of medication. by both your medical staff and the governing body. They'll verify these policies cover who is authorized to administer medications and that they're being followed. Our physician order is next. They have to be prepared according to those orders. Now, how you do that, how those orders are done is up to you. So it has to be documented and signed off by someone who's allowed to do that. On standing orders, these are the ones where nurses, those who are authorized, can give these medications without having to track down the physician ahead of time. They also talk verbal orders. If you're going to allow verbal orders, please use them infrequently. There are 4 items that must be in your policy and procedures for verbal orders. There are 2 main changes that happened. These are, again, in the medical record section. It's not in the nursing section, which do allow others than that ordering prescriber to sign off on them. Blood transfusions and IVs, they've included this in the nursing and medicine areas. So it has to address how are you going to give it? What vascular route? Are you going to allow it by a central line or only peripheral? Along with that, we got to monitor our patient. They talk about IV opioids separately. Again, they've listed out some of those risk factors for patients getting opioids. On your post-op patients, again, have policies that alert what you're going to do for those. CMS does note those recommendations. Adverse drug reactions or events. So back to blood administration, we know we have to have correct patient and blood product. Your staff must be competent not only in venipuncture, but using that access device. On administration and timing, and of course you have to have a way to report our reactions and adverse reactions. On the reactions and errors. So have a policy and procedure to make sure those reactions are reported internally. And immediately, the next 2 items, the next 2 tag numbers I combined, and that is self-administration or meds from home. That policy must include that you must have an order. Patient may self-administer. Now, this is optional. You don't have to do this. So you may need to supervise the patient the first couple times or the caregiver, whoever's doing it. So for the rest of the time, I want to talk not only opioids, but some of the risk. But before I do that, I'm going to talk about PACU, your post-anesthesia care unit. You are expected to have policy and procedures on the minimum scope and frequency of monitoring consistent with the standard of care. Safe opioid use. We know it's been in the news. Joint Commission got involved in this because they also recognized that we need to have something in place for pain assessment and management. That's why leadership is so important, elements of performance, because leadership is a key factor. As far as pain management, that there is a leader or a team that is responsible for pain management. Staff and providers are given those education resources so we can improve our pain assessment, that we identify our treatment programs that we can use. SAMHSA does have a treatment locator service that's available, that leadership works with our staff. We also talk in medical staff for Joint Commission, their leadership role to improve quality of care and safety, and that includes pain assessment, management, and opioid prescribing, and then provision of care. It is either treated or the patient's referred out. How are you going to do it? And of course, we want to involve the patient. We also have to monitor those who are at high risk for adverse outcomes, that we can assess and respond to what the patient needs. And of course, educating not only the patient, but their family. And their performance improvement, we've talked about medication administration must go through your PI, your QA-PI program. And also some national guidelines, starting with CDC. Yes, they were involved in our opioid guidelines. 2022, they put out practice guidelines, but there were 12 recommendations. They grouped it into 4 areas of consideration. The 4 areas you want to consider. AHRQ, Agency for Healthcare Research and Quality. They have some information on treatment for acute pain, not chronic, but acute. And of course, the evidence map. And then we have the National Action Plan for adverse drug reactions prevention. Health and Human Services, they found 3 classes of medications normally are the most common when there's been a bad event, and errors in particular. Opioids, it's one of the 3 targets drugs, very common in adverse drug events. There's data on here that has more than 100 million Americans annually are affected by chronic pain. Now in here, they don't talk about abuse in the plan. They have treatment guidelines, came out in 2015 and includes medication, telemedicine. AMA has recognized we have to end this endemic. Health and Human Services, again, guidelines for tapering opioids. Victor, I have one that was sent to me. Will you be discussing what the hospital did? Yes. Thank you for listening. Thank you for putting up with my voice. And with that, I'll send it back to Victor to conclude us.
Thank you, Laura. So that does conclude the session all. Now you all can disconnect and have a great day. Thank you very much.